Good evening, and welcome to the graduation of the Advanced Education and General Dentistry program. My name is Greg Hand, and I'm the Dean of the College of Health Professions at Wichita State University. Welcome to the graduation ceremony. Let me thank all of the graduates of the dental residency program who have put their trust in us to train them so they can go out and have huge impact in the community. And welcome to the new residents who are coming in for the next session. Our residents graduate, they have huge impact in the state of Kansas and across the country, and they are really the leaders in terms of dental health and oral health in the United States. We are the only dental program in the state, and so it's important for us to have students who come through Kansas. Many of them stay in Kansas, many of them go in other places to have such a huge impact. With that, again, thank you for being here for our graduation ceremony, and let me introduce to you the program director for the AEGD, Dr. Dean H.
Welcome. Today is about celebration and anticipation. We celebrate the old, we celebrate their sacrifices, we honor their families who have uprooted to come and be here with Kansas. We recognize the foregoing of a salary, the acceptance of a modest stipend to be here with us. Along with the celebration, equally we are excited about the anticipation. We're excited for the new residents that come in to replace the old residents. Today, we anticipate a new page. That page in the new residents will be a chapter in their book. That chapter will be the journey to Wichita State. That is your book, and next year we invite the new residents to also be on stage to share their journey and their story. To the faculty, we know it is worth it. You residents, you enrich us, you make us better. There's not time today to thank all my team. I do want to recognize team leaders. Assistant Dr. May, you and I meet many times after clinic out in the parking lot with a little faculty huddle. Kathy Franks, you are our lead dental assistants. You're the go-to, and you're always a step ahead of me. Stacy Greer, you're a clinic manager, and you're awesome. You save the clinic, you're the lifeline, and you're the second point of contact for the residents' experience. Next to my managers, Amanda Connor. You're the first point of contact, the first touch point, the night calls, the weekends, because that's when the residents are available. That is when the dental students are available. They work very hard in their preparation to come here. What we want as faculty, we want to pass on our legacy, to carry our torch. We want the residents to carry our experiences with them to light the way into the unknown future. The residents can't see all because they can't see what they can't see. We'll explain that a little bit later. What the faculty want, we want to leave our legacy with the residents. We want the resident to carry our torch. We want the resident to carry our torch of experience. To the resident, you'll carry your torch with you to light your way. You can't see what you can't see. The residents will be sharing their academic accomplishments today in their patient care showcase. We have 5 residents presenting 5 presentations, each 10 minutes or less. Dr. Tsai is going to kick us off. Dr. Wang is going to be our anchor. Dr. Soma, Keck, and Swisher will be the lead centers. Be mindful that today also has dental surgical cases presented. This clinic and the residency covers everything from treating caries to managing carcinoma. Thank you very much.
My name is Jason Tsai, and I'm one of the 5 Wichita State University AEGD residents from this past year. For the next couple of minutes, I'm going to be chatting with you about restoring the aesthetic interface, 3 cases that I had from the year 2020 to 2021. A little bit of background about myself. I went to the Rutgers School of Dental Medicine and graduated in May of 2020, and I've been out here at WSU pretty much ever since. On the personal side, I was raised up in Topeka, Kansas, not too far from here, and my wife and I had a residency baby, little baby Nicholas, that was born in January. So, as way of introduction, I have 3 cases again from the aesthetic zone to be chatting with you about, and as I was pulling this presentation together, I was wondering how I could tie it all together. And I thought about this often cited quote from the Irish playwright Oscar Wilde, and it goes, you've heard of it, imitation is the sincerest form of flattery. So how's that relevant? Well, in the first case, a number 9 fracture, a lot of us know that matching a central incisor to another central incisor is considered one of the more difficult things to do in dentistry, so imitation is the sincerest form of flattery when it comes to nature. In a second case of full arch alveoplasty, in which an attending oral surgeon did one side of the mouth, and then I copied him on the left side of the mouth, imitation is the sincerest form of flattery when it comes to an attending's expertise. And in a third and final case, when it comes to composite veneers, in which a dental lab did a really great job with their digital wax-up, imitation is the sincerest form of flattery when it comes to simply mimicking that lab's digital wax-up. So that's sort of going to be the through line that goes throughout this presentation, and why don't we go ahead and get started. The first case is Cody R. All names have been changed, and it's a number 9 fracture that went into the ferrule. Cody was a 54-year-old male when I met him in November of last year, and his chief complaint at that time was my front tooth while eating pizza. And you can see in this PA that it's a fairly significant fracture. It ended up actually being an Ellis class 3 fracture that involved the pulp, so it was quite painful. So for Cody, we ultimately took him through root canal, post-core, crown lengthening, and a new crown, all the while trying to imitate nature. So this is what I'm going to be talking about in this section. So we pick up the story here at pre-crown lengthening because the root canal has been done, the post and core has been done by myself, and I realized that this is an oblique fracture that necessitates additional crown lengthening, especially on the mesial and the distal aspects. And you can see that in that blow-up picture on the right side of your screen. The reason why we do this is because we want to respect the biologic width, and even beyond that, simply to expose additional tooth structure to achieve a ferrule effect and to accommodate the restorative itself. And so here we are in the surgery day with Dr. David May. He's one of our fantastic faculty here. He's a periodontist by training. And you can see him measuring the mesial and then doing the mesial, and then I ended up measuring the distal and doing the distal. So that was a fantastic experience. A quick slide about temporaries. I did temporaries twice on Cody. The first time in a unique sort of way was as I had finished the root canal and I had plucked out the number 9 crown and figured the best and quick turnaround sort of solution was to hollow out that tooth and then to put it in place with some flowable composite there in the interproximal regions, and it worked out for him. It worked out for a couple of weeks until that tooth started yellow a little bit, as you can see on the left-hand side. And that's when ultimately we had a lab-made temporary made out of resin as we were trying to set the margins and guide the soft tissue into its correct form. Here's a quick slide about the final impression. We selected shade 2M1 from the Vita Tooth Guide 3D Master Series. And then here's the result. So is it perfect? No, it's not perfect. The value is probably a little bit too high, but was the patient satisfied? Yes, he was certainly satisfied. He's a professor here actually at WSU, and he wanted to save the tooth as much as possible, so we gave him a relatively quick turnaround and we were able to save the tooth root. So, moving on to the next section, this is a full arch alveoplasty for patient Nicole H. And she was a 69-year-old female when I met her in August last year, so she was one of my first patients. Chief complaint was all my teeth are loose and my smile has changed. You can really appreciate that in this retracted view from that transition exam appointment. She has generalized chronic periodontitis. In today's classification, we would probably call that a stage 4 periodontitis with a grade B or maybe grade C rate of progression. And you can really see that in this panoramic x-ray in which the bony support is quite unfavorable. The crown to root ratio is quite unfavorable, and she has active infections in her mouth. So for Nicole, I ended up taking out all her top teeth and all her bottom teeth in 2 separate appointments, and of course had interim full of her fulls ready to go for those appointments. And our hope always is to garner the best functional and aesthetic outcome, but as you can see in this next slide, the aesthetics were simply incorrect. On the left-hand side, her natural smile was acceptable, but on the right-hand side, her high smile, or her cocktail party smile, or sometimes called the Duchenne smile, shows too much pink acrylic, the denture teeth are too small and blunted, and she simply didn't like the aesthetics, and she was right to feel that way. So we diagnosed her with vertical maxillary excess and a hypermobile upper lip, but even beyond that, she had significant buccal exostoses and irregular healing that you can see in this next slide. So this is the surgery appointment for the top alveoplasty. I did this part of the appointment with Dr. Dean Elledge, our dental director, and we used a wand STA system to pretty reliably, from just maybe 2 carps of 2% lidocaine, get uniform blanching of the maxilla. And this is a quick slide showing that we went to the incisive foramen and also bilaterally at the greater palatine foramen. But really most applicable to this presentation when it comes to imitation is the sincerest form of flattery. I have to give my thanks to a local oral surgeon, Dr. Christopher Harris, who did the right side of the mouth. Then I did the left side of the mouth. It largely featured side-cutting rongeurs and bone files, and then we sutured everything up. And I think you can see that he did a nicer job because his sutures look nicer on the right side of the mouth, but it was a fantastic experience. And next steps for Nicole H is begin fabricating that full upper once everything is healed up top. I've already done the lower arch alveo, and then we'll have to plan and execute the 4 lower implants because she does want an implant supported overdenture on the bottom. So we're going to move on to our third and final case, and that's Jane H, and this is a case of composite veneers. So Jane was a 77-year-old female when I met her in December of last year, and her chief complaint was binary. Number 1, my upper crown has got a crack in it. And by that I mean the following. She had Emax crowns at number 8 and number 9, and number 8, when I saw her on December 10th of last year, had a hairline fracture going horizontally across the porcelain. It hadn't quite fractured off yet, but it was a concern of hers. At that transition exam appointment, I also noticed that number 9 needed to be retreated, so I did that retreatment in January of this year. So Jane sort of got lost for a couple of weeks, and I didn't see her at all until she ultimately did come back in my chair for that number 8 repair because the porcelain did break off after all, and we repaired it with shade C1 Filtech. So that's the photo that you see there. But her secondary chief complaint was, I don't like how my neighbor teeth look. And by that I mean the following. In this blown up picture on the left-hand side, you can see that the laterals, number 710, appear darker, and they are certainly set back. They're palatal to the ridge. And this is accentuated by the fact that at the time, number 8 and 9 were different color crowns. And the canine teeth or the eye teeth appear to be somewhat rotated and look a little bit larger from the facial aspect. So I asked Jane what did she want to have done, and she said to have 7 and 10 fixed up for cosmetic reasons. And I said, well, we could do crowns, but unfortunately that was too much for her. She was already paying for number 8 and 9 to be redone. I said we could do veneers, porcelain veneers, and she also said that was a little bit outside of the range of her pocketbook. So I said, how about composite veneers? And she thought that was a great idea, and that's what we went with. So here's my lab prescription. I'm asking for shade C1 of number 8 and 9 crowns, but chiefly when it comes to our conversation here tonight, for number 1, the number 1 point that is please wax up number 7 and 10, bringing the facial aspect more facial. The patient dislikes how the laterals have always been palatal to the ridge. So here's the Regional Labs digital wax up. You can see they did a great job with the contours, and the incisal edges are much more in line with the neighboring teeth. Again, imitation is a sincerest form of flattery. All I have to do now is replicate this in the patient's mouth. Before we go into the appointment and how I actually did that, as a quick note, the lab had noticed that in order to make number 8 and 9 crowns fit really, really nicely, we needed to do a little bit of interproximal reduction on the mesial of 7 and the mesial of 10. So that's what these red markings are shown on the dies here. So here's our appointment, and I looked back and it took us 2 hours. We did 5 things overall. We removed the temporaries, we did the IPR number 7 and 10, we ensured that 8 and 9 had a passive fit throughout, we then did 7 and 10 composite veneers without 8 and 9 on because we need that extra space to play with, and then finally we cement number 8 and 9 crowns. So let's go ahead and take a look at that. On the left side, number 1 shows the temporaries off. On the right side shows the IPR finished and also 8 and 9 passively fitting. They're not luted in at this point quite yet. But the bulk of this appointment was at this 4th step of doing the composite veneers. So let's talk through this real quick. We did a vacuform stent of the digital wax up. We ensured the vacuform was fitting in the patient's mouth before we started. We used Teflon tape isolation and then etched in bond the regular old protocol on number 7 and 10, which is 38% phosphoric acid, and then Scotch Bond. We use petroleum jelly on the adjacent teeth so nothing sticks, and shade C1 Filtech to match that C1 8 and 9. We seat the entire prosthesis, right? We cure it. We spend time shaping the anatomy and polishing, and then we make sure that number 8 and 9 crowns fit throughout. And added a quick little cartoon there by number 8 because it shows a sandwich being crossed out. And as you might expect, when you're putting on uncured composite, curing it on top of a lateral incisor, what you don't want to have is a sandwich effect that's not smoothened out and nicely shaped. So a large chunk of the time in this procedure is spent at number 8, where we're ensuring that everything still fits with 8 and 9, but it's not a sort of a sandwich appearance to 7 and 10. So here's the final slide. She went from the left-hand side to the right-hand side. Again, that's 2 new full zirconia crowns, 8 and 9 shade C1, and also the composite veneers at 7 and 10. This was an additive, reversible procedure that yielded predictable aesthetic outcomes. All I really had to do was give direction to the lab and imitate their wax up, and the patient was very happy with the result. So that's it for me. I hope you enjoyed the presentation. If you have any sort of questions, that's my contact information, and have a great night. Thanks.
Hello everyone, my name is Lucy Swisher, resident in WSU AEGD. I graduated from UMKC Dental School in 2020. Before that, I completed a 5-year PhD program in chemistry from Kansas State University. I was born and raised in China. This is my family photo taken in China with my parents, my husband, and my firstborn daughter. Of course, can't forget the newborn baby. You may ask, what does a girl from Midwest China, married to a farm boy from Kansas, a mother of 2, know a thing or two about chemistry and nanotechnology, have anything to do with dentistry? Well, the answer is everything. I love the art and science about dentistry, and I came to WSU AEGD to learn more and be a better clinician by putting tools in my toolbox. Today, I'm going to talk about some of the tools that I have learned in AEGD through 3 clinical cases. The first case is complete denture case. Patient came in the office with non-restorable dentation and want to remove all the teeth and restore with a removable complete denture. This is patient panoramic X-ray. Obviously, all his dentation is non-restorable with several impacted anterior teeth. This patient was referred to our surgeon to have full mouth extraction. There are several unusual things about this case. First, excessive gingival display in full smile. It will be magnified if denture bases are overlaid on the ridge. Second, no posterior interocclusal space with gingival display in the second molar area. So this case is very challenging cosmetically. Even a former prosthodontist faculty said this cannot be done in our clinic during a consult. Bone recontouring is expected to achieve both functional and cosmetical outcome. This photo shows patient smile after full mouth extraction with alveoloplasty completed by oral surgeon. The maxillary arch still seems dominant. Interim dentures were made beforehand and delivered to patient after the surgery. These are patient's interim dentures. You probably noticed that there are no posterior teeth in these dentures and acrylic base is kind of thin, since there's no space for the lab to set the posterior teeth with patient's original bite. A close-up photo with patient wearing the interim dentures. The solution here is to open patient's bite. Since patient already have existing prosthesis and he likes the looks of it, so in the first appointment, the dentures were duplicated and bite was taken and sent those to the lab. Second appointment is wax try-in. Posterior vertical dimension is opened in order to create space for both acrylic denture base and the denture teeth. And using the existing denture as custom tray, border molding this and take a final impression. The new set of denture was delivered in the third appointment. In fact, patient loved his new smile so much and requests to remove the block from his eyes in this photograph. Let's move on to the next case. In the second case, patient came to office with broken tooth number 11. There are several challenges about this case: minimal ferrule and minimal interocclusal space to restore tooth number 11. Stern gold attachment gauge demonstrates how limited the interocclusal space is, less than 2 mm, and the first scale on this gauge is 3 mm. There is no space for traditional core buildup and a crown. Though we don't do it very often in our clinic due to expense and time, in this case, however, we decided to make a custom post and core with metal crown margin. This slide shows after elective root canal treatment and the space of the post was accreted. This slide shows that we capture both crown prep and post space in one impression. After inside canal was lightly lubricated, orthodontics wire with adhesive was used to carry and support the impression material into the canal. We did 1 cord pack twice technique for this impression. After we pull the cord, we can even see the impression capture the ligament of the tooth root. 2 mm parallel tooth structure used as the ferrule, which was surrounded by metal crown margin, and just like how the wine barrel was made. This slide shows the cementation appointment. The metal color of the crown surrounds the subgingival ferrule on the tooth, which will achieve the maximum strength. And another important point here is we need to eliminate the canine guidance in order to achieve longer longevity of the restoration. And I was told that you only need 2 tools in your life. One is WD-40, another is duct tape. Well, WSU AEGD has taught me that this statement is false. Let's move on to the next case. In case 3, the challenge here is not enough keratinized tissue at implant site number 19. The solution is free gingiva graft. An incision was made at the junction of the free and attached gingiva. Keratinized tissue was harvested from this patient's palate. A surgical stent was placed on patient's palate for hemostasis and for patient's comfort. The tissue was sutured at the incision site. 1 week and 3 weeks post-op photographs showed normal healing, and the implant now is ready to restore soon. I want to give thanks to our periodontal faculty, Dr. May and Dr. Weigel, endodontics faculty, Dr. Masler, and oral surgery faculty, Dr. Harris. I also want to thank our hardworking assistants, Kathy, Olivia, Cassie, Tanya, Delaney, and Anna. And I also want to thank Kaler and Root Labs for the effort to help us with the cases. Without all your support, we could not deliver the best care and service to our patients. The next step is to hand over all my patients to next resident Dr. Sherwood, who will continue to provide great care to them. Thank you.
Hello, I'm Dr. Keck. I'm one of the residents here at Wichita State's AEGD. I come from Nebraska, where I went to dental school, and I decided to come to Wichita State for this program after getting a true sense of their passion for teaching, and I was eager to learn. So I feel blessed to be here. I got to do more advanced cases this year, and I'm excited to talk about one of those cases with you all today. So I titled this case, Building a New Anterior Guidance, and I did this on a full arch. So my patient is a 96-year-old female. She presented to us for a new patient exam with her chief complaint being, my crowns are breaking and I'm worried they're going to fall off. This photo here is how she presented at her new patient exam, and you can see the chipping and the breakage that she is talking about along that incisal edge. You can also see on her posterior mandibular teeth the wear that's going on there. You also notice that in a full smile, she is showing her mandibular gingiva. So as we move forward with her treatment, we can predict that she will be showing the dental work that we plan. So an occlusal view here, again, you can appreciate all of the worn tooth structure on her posterior teeth here. We deemed 19, 20, 29, 30, and 31 as unrestorable. And here's an occlusal view of her maxillary teeth. Again, you can see the wear, the chipping, and the breakage that she's talking about on her existing crowns. And here we are measuring the thickness of material that she currently has. And you can see we're probably right about minimum thickness. And due to the wear, we don't have much tooth structure to gain any thickness. So we know right now that we need to increase her vertical dimension. Here's a buccal view. Again, you can see how worn these posterior teeth are, and you can even see her pulp is right there. The other side looks pretty similar, and this shows how much supereruption has occurred over time. Again, that's another sign that she has lost some vertical dimension. So the first question we asked ourselves was, why are the existing restorations and dentition failing? And after having multiple conversations with the patient and obtaining a good, accurate history on her, we decided that she had a multifactorial etiology. So we diagnosed her with erosion, abrasion, attrition. She had recurrent decay and defective restorations. So the treatment plan, we decided it was time to increase her vertical and make her a new set of full arch crowns, and we were going to do this with multiple sets of provisionals. For her mandibular arch, we're going to extract the hopeless teeth and get her ready for some implants. So we started with a diagnostic wax-up for an occlusal analysis. This wax-up was done at an increased vertical, and we used this as a guide for her provisionals. So the patient had both chairside fabricated provisionals, as well as we're going to make her a set of lab fabricated provisionals. And our goal with those provisionals is to have her try them out for a true trial period and have them look and feel as close as possible to the definitive restorations so that they can be a true trial period for her, and she can try out the aesthetics, evaluate for any changes in speech, test out her new vertical dimension and occlusion, as well as it gives us time to evaluate her pulpal status and the thickness of the material, make sure we have enough. So we started by removing all of her existing restorations, and we did this in 3 appointments in 3 sections. So we had her 3 appointments all during the same week. We worked from the right to the left, and as we were moving along, you can see that we increased the length on her, and by the time we were done, she ended up with a cant here, and this is important because this is something that the patient will notice, and it's something that she did notice. In fact, it's the only feedback that she's given us so far. So once we had the patient back for a full arch impression to send to the lab to fabricate her provisionals, we were able to take off all of her existing provisionals and make her a new set all at once and get a better aesthetic result. So for her lab fabricated provisionals, we thought the most important step here was to verify the centric relation. We wanted how the patient's opening and closing to match what the articulator demonstrates. And we did this in a couple ways. One way we did it was by taking a bite registration and looking for the burn through. And this corresponds with her first point of contact as she's closing. So we verified this as we were looking clinically. Another way we did that was by taking an impression of the temporaries, how they were seated in the patient's mouth, and we sent the lab a photo of her new anterior guidance and occlusion so that they could match that in the lab. So you can see here the 2 sets of models here. They were used to cross-mount and verify that we did have the correct centric relation. The lab was also able to evaluate how much vertical dimension we needed to increase, and they gave us 2 millimeters. So here's some before and after. This was the first set of temporaries. And here's some more before and afters. We did make the patient an interim partial, and like I was stated in the beginning, you can see she's got A lot of pink acrylic showing, which is something that we predicted would happen. So her lab fabricated provisionals are here, and we are going to be seating those shortly, so the patient will begin her true trial period. Once the patient accepts those, Dr. Casserly will then take over and be able to work on her definitive restorations, as well as place some mandibular implants for her. So I want to say thank you to all the faculty, staff, and dental assistants at Wichita State for all your mentorship and your help this year. I really feel like I learned a lot that I will be taking with me for the rest of my career. Special thanks to Dr. Carnahan for all of his tips and tricks on how to section and remove crown and bridge work effectively and safely. That definitely came in handy for this case. Also, special thanks to my dental assistant, Anna. I think one of her very first days as a dental assistant was with me doing a full arch impression and temporization, and she did great. So way to go, Anna, and thank you all for your attention today.
Good evening, everyone, and thank you for joining in. My name is Michael Soma, and I'll be taking over for the next 10 minutes. I'll be sharing one of my favorite cases from this past year. About me, I was born and raised in South Florida, married to my high school sweetheart. She's an attorney back in South Florida. I went to Florida International University for my undergrad. From there, went on to Case Western Dental School in Cleveland, Ohio, and then ended up here in Wichita. Leaving dental school, I knew I wanted more experience in treatment planning of complex cases and become more efficient in surgical and cosmetic dentistry. My sister and brother-in-law on the left side of the screen are both legacy residents of the program from 2017 and are now practicing dentists in Wichita. They told me about their experience here, and they learned so much and how it's propelled their careers. I knew this was a place I wanted to be at. My wife and I have been doing long distance the past year, and I hope she's ready to have me back full time in South Florida. All right, so let's get started. It's a 72-year-old female patient. Due to the complexity of the case and time allotted, we will only be discussing treatment for the mandibular arch. Her chief complaint is, I hate my unmatched teeth, my bottom tooth is loose, and I can't eat certain foods. Note here the large radiolucency under 25. So this patient was not happy with her teeth. All she noticed were 3 bright crowns that didn't match her natural teeth, and every time she looked in the mirror, it reminded her of her car accident 40 years ago. She isn't happy from an aesthetic standpoint or functional. And after 4 years of avoiding the dentist, patient is ready for a change. Clinical exam, poor oral hygiene, periapical radiolucency at 25, some mobility in her lower incisors, an anterior stub up in the occlusal and gingival plane. She's got some infractions in her bicuspids, and tooth number 18 is non-restorable. So our treatment plan, we'll start with the lower arch. We'll crown prep 22 and 27 for a 6-unit bridge, extract her lower incisors, do the fillings on her bicuspids, extract remaining non-restorable molar that you can see here in the back right photo, and place implants at 19 and 30 for single crowns. Again, on this patient, we talked about possibly doing an implant bridge for 23 through 26, but due to finances, we elected to do tooth-borne 6-unit bridge. Our first hands-on appointment, we elected to keep it short in order to gauge how the patient would cooperate in the chair during future appointments. So we prepped 22 and 27 for crowns. We used our Trio scanner to make digital impressions for a 6-unit PMMA temporary bridge and send it to lab for fabrication. Provisional crowns were then placed on those 22 and 27, and patient was dismissed. About 2 weeks later, her second appointment was day of surgery. Already had the initial preps, which you can see on the left photo. The PMMA temporary bridge will be delivered at the end of this appointment. I was fortunate enough to have the guidance of Dr. Code for this procedure that involved more than just extractions. Due to vertical bone eruption in the anterior region, an alveoplasty to bring the bone contours down to level the canines was done. We were able to use the temp bridge as a reduction guide to get the bone down to the exact level we needed. And during surgery, after removing the infection, which we saw earlier, we encountered complete obliteration of the lingual wall around site 25. To bulk that site back up for socket preservation and to get adequate gingival contours for the pontic sites, we placed 0.5 cc's of mineralized ground cortical bone, followed by a resorbable collagen membrane, from the lingual site and carried it over to the buccal. The picture on the left, you can see we were able to get primary closure. And by interlocking the papilla, we were able to keep a great amount of the keratinized gingiva. On the right side, you can see we were able to deliver the temporary bridge same day and confirm adequate reduction under the ponic sites. So to recap, it was a 2-hour appointment. Patient came in looking like the photo on the left, only she had the provisional crowns on 22 and 27, and she left with this temporary bridge. On a 1-month post-op, this is what she looked like. Oral hygiene instructions were re-emphasized at this visit. We received feedback from the patient whether she was pleased with the aesthetics of the temporary bridge or if she would like to make adjustments for the final. It was at this time that we also decided to drop the finish line on tooth number 22 for the final bridge prep. Our third hands-on appointment, first thing we did was we checked healing on the ponic sites. Then we modified the preps on 22 and 27, and patient again confirmed aesthetics for the temporary bridge. I extended the margin to the equal gingival on the root surface. We used our very own WSU AEGD shocker block, which we use for all of our crown and bridge work. This is my burr of choice for this type of preparation. It's a 254 medium grit gold-plated curettage burr. You can see I've already adjusted the preps on the top right photo, and on the bottom right photo, you can see my sloped chamfer at the gingival margin. We notice that it's less aggressive than a coarse diamond and provides a smoother finish. Day of delivery, we were able to restore the lingual wall defect that was present at site number 25. We were really proud of that. Our final bridge, patient was very pleased with the result and excited to move on for the restorations in her bicuspids. Our before and after. This slide lets you appreciate how dental work can impact a person's confidence tremendously. Here, we were able to correct the occlusal and gingival plane with a much more aesthetic result. You can also see our fractions were also filled in this photo as well. As clinicians, one of our goals is for our patients to be excited to look in the mirror and at the dental work we have done for them. Patient is happy and excited to start the next phase of treatment with our new resident, Dr. Wang, who will collaborate with Dr. Weigel and Dr. H for the next phase of treatment. I want to give a big thank you to everyone watching. I hope you got to learn something and see the kind of dental treatment we were able to perform for our community here in Wichita. I came here to learn and grow as a clinician, and I am grateful for the opportunity this residency has given me. I want to thank Dr. Elledge and the top-tier faculty he has put together. Thank you again to Dr. Code and Dr. Weigel for your support on this case. And a special shout out to all of our amazing assistants, Kathy, Olivia, Tanya, Cassie, Anna, and Delaney, who are a huge help throughout this treatment. We have an amazing team of faculty and staff here, and I wish you all the best, and I'll miss you guys. Take care.
Hi everyone, I'm Dr. Wang, the dental resident at Wichita State University, AEGD Dental Residency. A bit information about me. I'm 2019 graduate from Boston University Dental School. After I graduated, I practiced dentistry in Boston before COVID-19, and then I moved to Wichita for my residency. How did I end up here? I just felt strongly that the team built by Dr. Elledge truly cared about me, not only as a clinician, but also as a person. And that is something that I truly value, something that I can lean on, something that I can grow with. During this 1-year residency, I've gained tremendous support from all faculty and the staff. It is a year of progress, a year of reflection and gratitude. And now, I can say in confidence that I am a better clinician, a better colleague, a better friend, and a better person. Without further ado, let's jump into my case presentation. So, today I'm going to present implant planning and placement of a 6-implant retained overdenture. As far as the restoration, it's going to be handed to the next upcoming resident, Dr. Wu. And I would like the audience to know that due to the complexity of the treatment plan and the purpose of this presentation, I am only going to present maxillary 6 implants. And I'm also a firm believer that by placing implants, I've got a better understanding of the surgical aspects of the implant. And that is just something that restorative dentists do not usually have. So the surgical experience in this residency really builds a solid foundation for future advancement of implant surgery as a general practitioner. So let's call my patient D. He's healthy. He's a very happy person who is really ready for dental treatment. And his chief complaint was, I want teeth to chew with. I want my denture to be more stable. And as you can appreciate, this is the pre-op panoramic x-ray. Patient has a lot of broken down teeth and with bruxism. That is just indication for a very heavy occlusion force and prior orthodontic malocclusion. So by placing 6 implants instead of 4, we actually improve the diagnosis of each implant because each implant would bear less force. And this is the patient wearing the upper complete denture opposing the lower teeth. And because we do restorative-driven implantology, cone beam CT was always used before the implant surgery. And I also utilize patient's upper complete denture as a template to make a radiographic guide. So after merging cone beam CT and 3D imaging of the guide itself, the average space analysis was about 8, and locator abutments were indicated for retaining the overdenture, which is more cleansable and repairable. And then let's talk about radiographic guide. So the first picture, you can see that patient wears the upper complete denture, and then I utilize this denture as a template to make this radiographic guide. And in this 3D image, you can see the 8 markers on the guide itself. And then the last picture shows the patient wearing the radiographic guide shown on cone beam CT. And in our clinic, we use Noble Biocare conical connection implants. And the first picture really just shows one of the examples of the implants that were virtually placed in DTS software. The second picture shows the surgical guide, and these 3 pins are called anchor pins, which help stabilize the surgical guide. And the numbers here are the dimensions of the implants. So during surgical stage, Dr. Alice recommended that I do 3 implants per appointment. So it took me 2 appointments to complete the surgery. And the pictures shown in this presentation were from the first appointment for the upper right side. And then in this first picture here, you can see the surgical guide was inserted in patient's mouth. I make sure that there was no wobbling, no rocking, and then after patient was anesthetized, the surgical flap was made. And in the third picture, you can see the surgical guide was placed back in patient's mouth. And just make sure that the surgical guide was not in the way of the guided drill guide inside the surgical guide. And then, as far as osteotomy, it was done through guided drill guide. And here in this first picture, you can see this is the key, and this is the pilot drill. So the pilot drill drills through the key that was inserted inside the guided drill guide of the surgical guide. And the second picture shows here, this is the anchor pin that I alluded previously that really helped stabilize the surgical guide. And after the osteotomy was created, I use the guided implant mounts to place the implants. So before unscrewing the guided implant mounts, I always make sure that the safety measures were taken. So in this case, I utilized the 2x2 gauze that covers the patient's airway and instruct the patient to breathe through his nose. And then the floss was also utilized. Just make sure that we do not drop parts in patient's mouth, and that is very huge in our program. And as you can see, the cover screws were hand tightened on top of the implants, and then the surgical flap was sutured up and the primary closure was achieved. So Dr. Wagel, who is a periodontist, really recommended that I place implants subcrestal at an average of 2 millimeters. That way, really protects implants from the pressure of the denture. And before the patient was let go, I make sure that the corresponding side of the denture really was relieved to not interfere with the denture. And this also assured patients' comfort during healing process. And I would like to thank Dr. H and Dr. Wagel for their guidance and help in this case. And this is the post-op panoramic x-ray showing 10 implants that I placed in patient's mouth, including the 6 implants in the maxilla. This is the end of my presentation. Thank you.
My name is Dr. Seth Sherwood from Wichita, Kansas. I went to dental school at the University of New England in beautiful Portland, Maine. I'm excited to come back home to Wichita and have pool parties on the weekends with my awesome co-residents.
Hello everyone, my name is Dr. Jay Bhakta. I am from Liberal, Kansas, and I went to dental school at UMKC School of Dentistry. I chose to come to Wichita for my AEGD just because of all the things I've heard from the past residents that have graduated and the great faculty from UMKC. I'm looking forward to learning and to challenge myself in the year to come and to spend good time with the co-residents.
Hey everyone, my name is Dr. Tommy Vu. I'm from Grand Rapids, Michigan, and I went to school at the University of Michigan in Ann Arbor. Go Blue. I'm very excited for this next year to learn with my co-residents and learn from the faculty and staff this next year.
Hi, my name is Zach Vogel. I'm originally from Cape Girardeau, Missouri, and went to dental school at UMKC. I'm really excited to be joining the team of residents here at Wichita State, and I'm looking forward to a great productive year.
Hello, my name is Dr. Megan Casserly. I was born and raised in St. Louis, Missouri. I went to Truman State University for my undergraduate degree, and I just graduated from UMKC School of Dentistry this past May. I'm looking forward to getting back into the flow of dentistry and getting to know my fellow co-residents this upcoming year.
Hi everyone, I am Dr. John Nguyen. I am originally from Houston, Texas. I went to Roseman University Health Science School of Dentistry in South Jordan, Utah. I look forward to residency in Wichita to learn amazing dentistry with great faculty and staff. Fun fact about me is that I love trying new taco trucks and looking forward to pool parties with my co-residents.
Those were amazing presentations, and it could not make me or my faculty, my staff, my entire organization more proud. I want to announce to the profession of dentistry that we at Wichita State have given you our best. The presentations is a reflection of the power of this organization, the passion, the fire, the spark. I would like to represent that with a chalice today. The chalice will contain the power, the fuel of the faculty. This is the energy that will carry you forth. The light brightens your way. It allows you to see where you could not see before. Over the shoulder, remember, we are always with you guys.